Thank you for participating in this session. First of all, I would like to thank Technopad for the invitation to speak at this session. In vitro diagnostic examination report either the value or the characteristics of a clinical property. Quantitative measurement procedures measure and report the value of a property of clinical samples. Qualitative examinations of clinical samples report characteristics of a property by placing them in two categories: binary, unordered, and ordered categorizations. Examination results are called qualitative. The meaning of a qualitative value is given in the examination procedure. However, there is a lack of harmonization between the different qualitative guides, including in the terminology. The IFCC and UPAC vocabulary is suggested. So, what is a qualitative test procedure? For a more straightforward explanation, we will compare the results of a quantitative test with a qualitative one. Numerical results characterize 140 millimole per liter, so the result is given by a measurement procedure recognized as a quantitative test. A reference interval can clinically interpret the result, for example, on the normal range. Positive is characterized by descriptive rather than numerical, so the result is given by an examination recognized as a qualitative test. Diagnostic can clinically interpret the result, for example, infected. Unlike quantitative analysis, qualitative analysis is reported by a qualitative result, such as positive or negative, or pass or fail. The qualitative tests differ from the quantitative tests principally because the property has no size, for example, dichotomous results. Examples: blood typing, where agglutination classifies a red blood cell type. On this case, A positive. Another example: the colored line used in an hepatitis C virus rapid test is another example. The colored line has no size, so it does not express a quantitative result but a qualitative level. In this case, two distinct colored lines appear, on the control region and another in the test region. The test result is interpreted as positive. Another example, an immunoassay to detect IgG and IgM antibodies of SARS-CoV-2. On this case, what is measured is a signal which cannot be proportional to the antibodies due to factors such as the affinity and the avidity. Cutoff is decision value, so a positive sample has a signal that is greater than or equal to the cutoff. This signal classifies the sample result as positive. A negative sample has a signal that is lower than the cutoff. This signal classifies the sample result as negative. In the case of competitive immunoassays, it is the reverse. Finally, the real-time PCR to detect SARS-CoV-2 RNA. So results equal or higher than the 95% limit of detection are classified as positives. For example, classification of the number of copies per milliliter. Lower results are classified as negatives. So what is the difference between quantitative and qualitative testing? Let us compare the sodium versus SARS-CoV-2. Sodium, one of the body's electrolytes. Determination of concentration, numerical value. Example, 140 millimole per liter. Sodium concentration in body has small biological variation. Reference interval is between 135 and 145 millimole per liter. Validation is based mostly on the total analytical error concept. Allowable total error is a size that is clinically not significant. Severe acute respiratory syndrome coronavirus 2. It is the virus that causes coronavirus disease 2019, recognized as COVID-19. So it is the cause of the COVID-19 pandemic. Screening and epidemiological surveillance tests are required. Detect indirectly via antibodies or directly via viral RNA fractions. Binary results are qualitative. Positive negative results are reported. Validation is based on proportions of true results by clinical sensitivity and specificity. For an explanation of qualitative test procedure application, we will see a SARS-CoV-2 infection curve in the laboratory view. The curve is only possible through laboratory results and performance. So, the seronegative window period for nucleic acid amplification tests is between 1 and 5 days. For serological tests, it is at least 7 days after symptom onset and could be up to 12 days. The incubation period is interpreted as the time between the day 0 of infection and onset of symptoms. This is the well-recognized scientific basis for determining which screening test is. So the screening test is a real-time PCR to identify virus RNA. And the epidemiological surveillance test is the immunoassay to detect SARS-CoV-2 antibodies. So, what is an internal quality control in qualitative tests? Method validation is generally well established. It is based mainly on Bayesian probabilities, mainly on clinical sensitivity and specificity. So, let's focus on internal quality control. So, again, what is an internal quality control in qualitative tests? Internal QC is intended for the continuous monitoring of the examination results on analytical runs. It is intended to decide whether runs are reliable enough to be reported. Some definitions are essential to an harmonized understanding. Analytical run is a series of measurements within which the trueness and precision of the measuring system are expected to be stable. Quality control material is a substance, material, or article intended by its manufacturer to be used to verify the performance characteristics of an in vitro diagnostic medical device. It is a liquid, frozen, or lyophilized solution appropriate for routine use. So, concentrations of QC material should be close to clinical decision limits. For the reference interval for sodium, 135 millimole per liter is the low limit, and 145 millimole per liter is the high limit. So, 2 QC materials are required and should be equal or close to these limits. Let's see now SARS-CoV-2. Clinical decision limit is the cutoff. Positive samples are used as control of true positives. Negative samples as control of true negatives. What is a cutoff value? For a qualitative test, the threshold above the result is reported as positive and below which the result is reported as negative. For clinical decision, based on qualitative results, we need QC material close to the cutoff value. So, weak positives as control of the signal level problem. And weak positives are related to the risk of false negative results. So, signals of true positive samples higher than the cutoff but close have a significant risk of misclassification, so that they can be interpreted as a signal level problem. But how safe is the cutoff value given by the manufacturer? Cutoff is related to the test intended use and given in the instructions for use. Sometimes approved by regulatory agencies due to the sensitivity-specificity trade-off. So when Sensitivity goes up, specificity goes down, and vice versa. For example, the trade-off in a blood bank screening test favors the sensitivity in relation to the specificity. Reagent lot-by-lot variation should not be clinically significant. The variation should not be the cause of false positive or false negative results. For a better understanding of the signals, we will consider samples from infected and healthy individuals. As we saw, the cutoff is the decision point for the classification. Most samples from healthy individuals are classified as negative, so true negatives. However, there is a risk that the party could be classified as false positives. Most samples from infected individuals are classified as positive, so true positives. However, there is a risk that the party could be classified as false negatives. False results are a major concern, as in the blood bank, due to the post-transfusion infection risk. In-kit versus independent QC material. Manufactured positive-negative materials are intended to compute the cutoff. Are intended to validate the cutoff based on manufacturer-dependent criteria. Positive-negative materials are not intended for internal QC. So, how can we monitor our results? Independent controls whenever possible. Internal QC materials are available from third parties. Weak positives are available for major MedLab instruments tests. Weak positives can be human samples. In-kit negative materials fit the purpose of negative results control. Let us show you the example of controlling binary results of viral SARS-CoV-2 RNA in a real-time PCR test. The attribute charts displays two dimensions of data: the control examination number and the type of binary results, true or false. In the green side are the true results, whether the true positives or true negatives. This side. The red side are the false results, whether false positives or false negatives. A quality control material with a concentration close to the 95% limit of detection is used, so a weak positive concentration. On this case, these points represent an out-of-control result, which suggests possible instability in the method. It is clinically important since it represents a false negative result. This result suggests a possible clinically significant risk, so the results of the analytical run in which it happened are rejected. A corrective action, preventive action, is required. Now let us show you the example of controlling binary results of anti-SARS-CoV-2 IgG-IgM immunoassay. Whenever the qualitative result is based on a cutoff and an ordinal scale value, which is numerical, and in which a result is classified as positive or negative depending on the cutoff point, the use of Levy-Jennings charts is a more powerful tool. Levy-Jennings charts allow illustrating random and systematic error, such as trends. That's not possible in a qualitative results chart. Levy-Jennings charts design requires the standard deviation and average. The results, such as signal to cutoff ratios, must comply with defined rule or rules. This case uses a single rule, 1-3S, so results out of control are those out of the average plus 3 standard deviation and average minus 3 standard deviation. The chance to violate the rule is close to 0.1% in stable conditions. In fact, what we control can be referred to as loss of clinical sensitivity of the tests, which is related to the risk of false negatives. The limit is illustrated in the red side. So, on this green side we have the in-control results, and on this side, so out of the interval average plus minus 3 standard deviation, we have the out of control results. A rule violation is identified. So, on this example, there is a risk of incorrect classifications of positives with an average close to 1.75. So the run results are rejected and the corrective action, preventive action applied. Note that the Westcott rules do not fit the purpose of qualitative tests. They fit the purpose of quantitative tests. Its application is a well-known cause of false alarms. A more in-depth discussion on qualitative QC is published in the book Quality Control of Qualitative Tests for Medical Laboratories. It includes a CD with spreadsheets and case studies. For more details on internal QC, see Chapter 7. The book is available on medlabquality.com, Westcott QC, and Amazon. Well, the first question: what are the main causes of errors in qualitative tests? Well, the main causes can occur either in the pre-analytical, analytical, or post-analytical phase. Pre-analytical errors are due to failures such as identification of sample tubes. Sample preparations for PCR tests takes place at this stage. Contamination is perhaps the main cause of error in nucleic acid amplification tests. The analytical failures are mainly due to the tests. The post-analytical phase is related to the reporting of results. The main cause in each of the phases is the operator. The next question: can we use the qualitative chart for immunoassays as an alternative to Levy-Jennings chart? Well, yes, we can use it. However, Levy-Jennings chart should always be the first option when binary results are classified on an ordinal scale according to a cutoff. As mentioned in the presentation, Levy-Jennings charts allow for more robust control. For example, we will be able to control prospectively through random and systematic error, as well as trends. For example, the beginning of a light source's degradation can be detected in a Levy-Jennings, not being detectable in a qualitative chart. In this type of chart, it would only be detected when it caused a false result. Third question: what should we do if there are no weak positive concentrations in the market? Well, higher concentration may be used. However, it should be understood that it does not control the signal level problem. Let us say it is a limitation of fitness for purpose. In some situations, there may be no samples with weak concentration. Dilution is an alternative, however, it must be taken with great care not to bring heterogeneity to the results. ISO 15189 does not limit the use of the concentration, for example, of a positive sample. Next question: is controlling negative results as important as positive ones? It depends on the intended use. For example, in tests for screening for infectious diseases, the trade-off favors clinical sensitivity in relation to clinical specificity. In this case, the risk of false negatives is critical and false positives are not. Thus, one can understand the control of positives as a primary. In this case, it is important to use weak positive concentration in the Levy-Jennings chart. The negative sample may be the one included in the kits, and the qualitative chart may be used. Another question: what to do when we cannot identify the cause of the error? Our experience says that this type of problem is mainly associated with the use of an inadequate internal quality control design. For example, the classic waistguard rules. This use leads to false alarms, that is, the result of the control suggests rejection, but in the real world there is no cause. In this example, looking for the non-existent is an impossible mission. When the quality control design is adequate, the probability of error detection and false rejection guarantees a low risk of false alarms. In this case, the fault is almost always real and must be identified, involving correction if possible, and corrective and preventive actions. The last question. Can systematic and random error be controlled in qualitative tests? And the total error? And the measurement uncertainty? Well, the systematic and random error can only be calculated when there are numerical results. In this case, the results must be on a scale, being classified according to an order, according to a cutoff. Here, they can be controlled as mentioned in the previous question. In the case of the nucleic acid amplification test, the clinical decision value is 95% limit of detection. In this case, the results are not binary ordinal quantities and can be interpreted as binary nominal quantities. Thus, in this type of test, systematic and random error control is not adequate. The total analytical error and measurement uncertainty is for quantitative results only. For qualitative results, examination uncertainty or 95% confidence intervals should be used, also known as condition uncertainty. However, the total analytical error or the measurement uncertainty can be used to calculate the gray zone. We note that only measurement uncertainty is recognized in methodology vocabularies.